Good morning. This is on yet. It's a pleasure to welcome you here today. This is an extraordinarily exciting day for me. It's not really because this is my first grand rounds as your chair. That's really not what today is about. Today is about much more than that. Today is about more than just honoring a great surgeon, scientist, husband, and father. Today is really about the future of UC San Diego as cast through a very important legacy, and the legacy of Dr. Hansbrough and the Burn Center. I don't live in the burn and critical care sphere, but I knew from clear across the country really how great the burn program here was at UC San Diego. Aside from being a really important resource for the community, it was a leader in the care of burn patients, advancing the field, and was known not just nationally but worldwide. Today is about a model of how academic surgeons can really make a difference. It's about being inspired, hopefully, by Dr. Hansbrough's legacy, and really by our visitors, who I think embodies everything that Dr. Hansbrough stood for. So I'm going to get out of the way, and I'm going to let Dr. Potenza and Dr. Coimbra manage things from here on. But thank you for being here. I look forward to getting to know each of you over these next couple of months in a very much more real way.
Thank you, Dr. Clary, and again, welcome to the 12th annual John Hansbrough Memorial Lecture. I was speaking with his wife, Wendy Hansbrough, and John Jr., who was up in the second row here, who have graced us by coming today. And I said, you know, it's getting to be that I really have to do a better job every year, because every year people move on and graduate, and the people who have actually touched and worked with John become less and less. So I'll try to breathe a little bit of life into his story. He certainly was a mentor when I was a trauma and critical care fellow here. He made sure that I knew who the boss was and what was the right way to do it and what was not the right way to do it. But he would sit down with me, and in very small tidbits, as we talked last night, little 5-minute kind of lecture sessions where he'd say, this is the way it is, let me tell you how that works. And if I wasn't listening, I missed the whole point. And then a couple of days later, he'd come back and ask me about that point. Did you get that? Do you see what I was saying? Do you understand where I'm coming from on this? And so that's how our relationship was, these little pieces of things that were talked about at the bedside or discussed after we did a tough case, or I was covering for him while he went off to a meeting, and he'd come back and he'd grumble a little bit and he'd say, what'd you do on that patient in bed 2? I'd say, have all this explanation. I had it all written down for him because I knew he was going to do this. And he'd talk to me and he'd go, I wouldn't have done that. I said, okay, well, tell me what, I'm trying to think like you think. He goes, that's your first mistake. Don't think like me. Think like you. And then you become the good surgeon. And so that was little things like that are what I kind of remember. So I'll just take you a little bit through his life. He was born in Virginia. He went to the University of Wisconsin, medical school over at Harvard, and then he trained out at the University of Colorado. And Colorado was a powerhouse at that time. It was a every other night call. It was a tough and it was a rigorous program. He went through there, got his first job there as director of the Burn Center, director of the emergency division at that time, and director of the SICU. So they used their people to cover a lot of areas. He was recruited here by Babs Musa, our second chairman, and came in the late 1980s and set up the burn unit, which at that point was still a relatively young burn unit, had only been around about 13, 14 years at the time. And both he and his wife, who worked in the burn unit, made it into the powerhouse that it has become. His main interest, I think, is to take care of patients, but his real passion was sitting in the lab or sitting at his computer. And at that time, they were kind of slow computers compared to what we have now, but banging out a paper. And he was the type of fella who could go from the bedside, talking about patients, working on them, to sit down in his computer, and within about 5-10 minutes, he was completely focused on where he was yesterday on that paper. I can't do that. I can't even come close to doing that. He was gifted in that sense. And then he'd go to the operating room, operate for a little bit with the fellows, come back to his desk, sit down, and then just continue. He just had a gift for doing that. You can see a number of the things that he had accomplished. This is when he first came out of training at the University of Colorado. And let me just tell you a little bit about some of his research things. He really was interested in early feeding of patients. He felt you could feed these patients during the resuscitation period. That was counter to the culture at that time. He demonstrated that we could successfully feed intragastrically, and later we can do post-pyloric feedings and do that early and feed right up to surgery or through surgery, depending on how the patients were doing and what position they were in. One of his passions, though, was to try and build a skin substitute. It's the Achilles heel of burn surgery. How could we make first an epidermal substitute, but more importantly, how can we make a dermal substitute that really works? Because if you think about it, it's your dermis that gives you your strength, your elasticity, and really allows you to be functionally mobile. He worked on this and worked on this and worked on this, and I'll tell you some of his discoveries here in just a minute. He was one of the co-authors of one of the first papers to come out of the National Burn Registry, which looked at our numbers for survivability. It questioned the box score, which said your age plus your percent burn. If it equaled 100, that was 100% TBSA. It was questioned back there. It's now since been modified that your age and your TBSA must meet 120 before you get 100% mortality. They looked at fibrin, seal, and multiple products that we now use today as commonplaces. The glues that we use, the thrombin, the recombinant DNA types of thrombin were being worked on at that time. And the last one on there, I think, to me, is one of the most important contributions that he's ever done. It was a product that was called Transhyde. Unfortunately, short-lived in the commercial market, but it was, if you will, a mosquito netting screen that was impregnated with fibrocytes, human growth factors, and kind of a glue, if you will. It's placed on intermediate to deep partial thickness burns. It really works well in kids. You know how much trouble we have changing bandages on kids every day. It's a sedation every day. It's a big project. This we would put on day one when they came in, and we would leave it on 10, 14 days until it would finally peel off. And if the wound was going to heal, it would be completely healed at that point. Tremendous, tremendous product that he was the genesis of. He looked at other things besides burns. He looked at soft tissue and dermatologic problems. He looked at toxic epidermal necrolysis, purpura fulminans. So whatever came, he kind of took. And he studied it, and he would think about it, and he would come up with a clinical pathway to deal with it. Just a few pictures of him. Here he is in the operating room. So I went back, and I didn't spend much time in the operating room because I was a fellow under Dr. Hoyt and the fellows with John, or Dr. Tenenhouse and a number of other people. I said, what was it like working in there? And he said, well, it's really good. But you never knew what was going to come the next minute because we'd just be working there and he'd stop and I knew something was coming and I'd say, well, what would come? And he'd ask me a question. And the question would be some pathophysiology of what we were doing, how we could fix that particular problem in a way that we hadn't approached it before. And he said, I was a fellow at that time, so I wasn't a real good operator on what to do and I couldn't think at that level and still operating at that speed. And he'd say to me, come on, come on, come on, come on. And I never felt like I would get a really good conversation in the operating room. And he said he told that to Dr. Hansbrough, and John said to him, he goes, I'm pushing you. That's what I'm here to do. I'm here to push you, make you think, make you work, and keep you moving. We can talk about this later when we really need to. So this was the look you never wanted to have on rounds, okay? This was the look that something you just said was wrong. You missed something. He doesn't quite figure out exactly what you're saying, and God forbid you kind of fudged it a little bit. You said you checked something, and you really kind of almost checked it, but you didn't. This is the look you got. This is the look you got, and you could be dismissed from rounds, and when you're dismissed from rounds, you disappeared. And you came back later, and you just went back to work. And this is just clowning around a little bit in the OR. So I learned what it is to be in OR too. You just spend hour upon hour in there. And so it gets, at times in between cases, you got to break the monotony a little bit. John was a great politician. He was a fellow who went out to try to get the grant money, a fellow to try and get community support. Here he is with Ron Roberts, with the county supervisors at that time, trying to elicit support for USISD, the burn unit, the injury prevention programs, and things such as that. He was very successful at doing that. These were a couple of the areas that were passion to him. He liked pre-hospital. He was very much an educator, and he wanted to teach the pre-hospital people what you need to do to take care of burns, to get them from point A to the burn center. Get them there alive, and do good treatment while you're en route. And that's not always possible. And one of the things that he became involved with was the United States Navy. And the Navy, if you know, sends out ships for 6 or 8 months. And on that is usually a very junior surgeon who is the surgeon for that small task force. And that person needs to take care of whatever comes in the door. It was in the days of beginning telemedicine. It was, how do we take education out to the troops, if you will? And he made videos. He made CDs. CD after CD. Wendy made CD after CD. Initial management of burns, bandaging of burns, treating this, doing that. And he was always a resource to the Navy when they had have questions or that they needed answered. I think this was a real passion. You'd see him grab his camera, always put on his leather coat when he did it, put on either his baseball cap, or they also gave him a Navy baseball cap, and off he went. And then I think a man or a woman is not the surgeon that they could be if it's not for their spouse or their friends. And I think the combination of Wendy by his side, of John Jr. growing up, and John's sister, it was a good unit. You can come here, you can work hard, you can go home and have a little bit of family life. So my intent was just to bring a little bit of life to somebody you probably never met, somebody who had a lot of influence on a number of the faculty here. And it's a great pleasure to welcome again Wendy Hansbrough, John Jr. Hansbrough, and I'd like to turn it over to my partner, Dr. Raul Coimbra, to introduce our guest speaker.
Good morning. Thank you very much, Bruce. That one is hard to follow for sure. It's always a great pleasure to introduce the John Hansbrough Lecture. We had great speakers throughout the last decade, and today obviously is no different. Dr. Edward Tredget from Alberta, Canada, graduated from the University of Alberta, did his general surgery and plastic surgery residency in the same institution, did a research fellowship at the Shriners Burn Institute at Mass General, and at the same time he was at the Shriners, he obtained a Master's of Science degree from MIT. That tells you a lot. He has received many honors and awards throughout his career. He is currently the professor of surgery at the University of Alberta, the director of the Division of Surgical Research, and the senior director of research. Ed has mentored a large number of Canadian and international researchers. He is currently the president of the Canadian Society of Plastic Surgery and the president-elect of the ABA, the American Burn Association, where he also served in many committees, particularly the program committee, and currently he's the vice president of the ABA. He's a member of other 17 scientific professional organizations. He's on the editorial board of 5 journals, including Journal Burn Care and Rehabilitation and the Journal Plastic, Reconstructive, and Aesthetic Surgery. He's a reviewer of other 39 journals talking about service in academic surgery, including Annals of Surgery, Journal Leukocyte Biology, Nature, Lancet. He has been a very important researcher in the field of burn and wound healing, and he has been funded continuously since 1987. He has studied all aspects of burn care and wound healing, which led to 179 publications in peer-reviewed journals, 33 book chapters, and several hundred abstracts and lectures presented all over the world. There is no question in my mind that Dr. Tredget is a true triple threat academic surgeon, leader, and mentor, and it's my honor and pleasure to introduce to you our 2015 John Hansbrough Memorial Lecturer, Professor Edward Tredget from Alberta, Canada. Ed, please.
Thank you very much for those kind words. On arriving here, I was happy that I was given a nice warm hotel room. I just came from Sacramento, and right now in Alberta, it's about 10, 15 degrees below, and there's snow all over the place. And I was visiting Dr. Greenhaw in his institution there. And we came a few days early, and he thought it would be a treat for we to go to see his cabin. So we headed back into the mountains, where we got to see more snow and ice and cold weather, which if you live in Sacramento is a bit of a treat because it's warm there all the time. but we had a great time there with his wife and family. Just to make this advance. Yeah, so I would like to explain to you that I knew John very briefly. I was a traveling fellow in about 1990, a few months after I was into practice, and I came here as part of a multi-site tour, and I arrived with another person who was familiar with the university without actually having talked to John. And so I was unannounced, and John came over and was friendly, and he showed me around and accepted the fact that I was sneaking around in his burn unit without any advanced preparation, and it was very good to me then. But I knew him more through the eyes of other people and through the work that he did, and he was very well respected. And one friend of mine that I think is really very important to the burn field, Steve Boyce, actually thought very highly, not only of John himself, but Wendy, he thought that the world of you, and I've seen your contributions through the eyes of others at the ABA as well. So two very important people, and I thank you for having me here. So I just like to be honest about the kinds of things I'm involved with. If you do what I do, you have many opportunities to be involved, and so I try to further our research through the support of these other people. So my involvement there is as an investigator only. And you'll see a little bit of one product that we've studied. But my goal really today is to try to talk to you a little bit about some of the mechanisms by which wounds heal with fibrosis instead of regeneration and no scar. To describe some of those features and an approach that might be useful to you, and then consider some of the novel and upcoming things that are important in scarring. So if you treat patients, you'd all like to see someone with an injury like this be able to go on and heal their wound without any scar. But the reality of the world is all too often we have many patients that have scar, and this is just some of quite a few that I deal with on a pretty regular basis. And if you're genetically predisposed, you can see that the extent of this problem can be very difficult. And then when you begin to consider how could you help a young person like this, you realize that your options to be able to provide care for this type of problem are very difficult. So the goal ultimately is to try to regenerate the picket fence after someone has just driven through it. And you'd ideally like to be able to put it back with the pickets exactly in the same place that they were before. But all too often we end up with a mature scar if we're lucky, but commonly this fibroproliferative disorder that we call hypertrophic scar or keloid. So our approach years ago was to begin to ask the question, how are the fibroblasts in the scar different than the normal skin? And so we use these series of site-matched biopsies to grow and explant the fibroblasts and then ask questions about how the cells are different. And I won't bore you with all the details, but the short of the very long story is there's things that the fibroblasts in scar make that they make in excess. There's more fibroblasts in number, there's more fibronectin, type 1 and type 3 collagen, TGF-beta, and some of the proteoglycans, particularly a large one called versican and another one biglycan, are produced in greater extent. But of the 30-odd fibroblast strains that we've studied, and there's a lot of heterogeneity, more commonly and more uniformly, what they're missing are enzymes which remodel the scar and degrade it, and they more commonly are missing some of the production of a small proteoglycan called decrin, and they don't undergo apoptosis because they're in a proliferative mode. So one of the other questions is, what does the depth of injury have to do with scarring? Because if you care for patients, you realize this is of some importance. And you see these kinds of cases that come, you treat them conservatively, you hope they get better, and as the wounds heal, they go on, and then eventually they get scar. Not everywhere, they get scar right in the deepest regions of the wound. But once they've got that scar, it doesn't go away. It's there for years, and it's a problem. And this is quantitated and approached nicely by Duncan and a group in Britain where they studied 113 volunteers and made a graduated incision in the lateral thigh skin where the incision got deeper and then allowed it to heal. And they found basically there was a cutoff point of about 0.56 millimeters in the lateral hip skin, beyond which you'd get scar, but within it you wouldn't, which I thought is quite interesting. So then part of our activities, our group, was to then look at the skin, and we took a dermatome and took the cells from different layers of the skin and began to examine them. And basically this is some of the data that shows that As you go deeper into the layers of the skin, the collagenase activity actually goes down, and as you go deeper into the skin, the production of collagen, exemplified by hydroxyproline, increases. Similarly, a fibrogenic growth factor that stood the test of time in scarring is TGF-beta, and in the deep areas of the skin there's more TGF-beta expressed and less TGF-beta 3, a putative antifibrotic form, and those layer fibroblasts make more TGF-beta in the deeper regions than they do in the more superficial. Another approach to this was to begin to examine the receptor for TGF-beta, and the type 2 receptor is the important component in the signaling, and in the deeper layers of the skin there is more message, there's more protein for the type 2 receptor, suggesting that those cells would then also be more sensitive to the TGF-beta signal. So one of my interests came from one of my mentors, Paul Scott, who was very good to me, and he spent a lot of time trying to understand Decarin. He crystallized this proteoglycan. It's a small proteoglycan that has a short sugar chain that has and a protein core that has a number of leucine-rich repeats. Decarin actually can bind to fibers and creates fiber bundles which are tightly packed and uniform, and creates a matrix which is important in skin where it's found most abundantly. So you get smoothly packed parallel array of fibers when Decarin is expressed, and when it's not present you have something else. And Decarin also has the ability to bind TGF-beta where it can neutralize this fibrogenic effect. And so you'll see in this same approach, actually both at a protein level with ELISA and message and with flow cytometry, the deeper layers of the skin produce less Decarin. So one of our graduate students actually in our lab cloned the Decarin gene, and again in the experimental work he reaffirmed the fact that the deeper fibroblasts actually produce less Decarin protein and less message. But what was interesting to us is that the deep dermal fibroblasts actually excrete or produce 3 microinhibitory RNAs which regulate Decarin's production in those cells. And when you try to counteract that with gene therapy, you can restore some of the function that occurs with overexpression of the gene in those cells. But with the lack of Decarin, the normal fibrillogenesis that you can study using Picrocereus red demonstrates more disordered fibers and thicker fibers that lead to a scar instead of normal skin. So more work. How do fibroblasts actually become involved or activated in the scar? And Howard Levison has this nice picture that depicts some of those things. And one of the ways is likely through toll receptors, which were originally described in Drosophila as fantastic or marvelous by a German group before Dr. Cohen won the Nobel Prize understanding it. And there's a number of different toll receptors, but what we studied is TLR4. It's a type of toll receptor that's most sensitive to LPS and other molecules which I think are more commonly involved in the burn field. And those fibroblasts in hypertrophic scar produce or express more TLR4. These are the activating molecules. These molecules, LPS, but also endogenous molecules such as damaged proteoglycans and other things that can come from the damaged tissue, independent of bacteria, can activate the toll receptor and create activated fibroblasts and healed wounds, but possibly scar as well. So fibroblasts can be pro-inflammatory. When you expose them to LPS, they increase the amount of inflammatory molecules like PG2, IL-8, IL-6, and MCP1. In hypertrophic scar fibroblasts, it's actually more sensitive, and they produce more of these molecules. What's interesting is that in the TLR4 pathway, there's a common intermediate called myelodifferentiating protein 88. It's in the blue box about just underneath the TRAP and TRAM. Anyway, that molecule is involved in the signaling intracellularly, and what you can do is use small inhibitory molecules, or siRNA, to inhibit myelodifferentiating protein and its expression in these cells. And in so doing, you can then turn off some of the pro-inflammatory molecules that are present as this occurs. And you can see there that both for PG2, IL-6, IL-8, and MCP1, complementary RNA does not do it, but the targeted mRNA actually can fix the inflammation that's produced. So this is part of our hypothesis. We think that in the deep portion of the skin are fibroblasts that respond in a different way than fibroblasts in the more superficial areas of the skin. But unfortunately, we're not so naive to think that the whole problem exists in the skin alone. There's an interaction that occurs, we think, with the bone marrow, in which there are cells that come out of the systemic circulation, enter the tissue, and contribute to the development of scar. And part of the signaling is through the toll receptor pathway. One of the reasons why we think there's more to this story than the skin alone is a condition called nephrogenic systemic fibrosis. This is a condition that occurs when you take someone in renal failure and you image using gadolinium. And gadolinium, once injected into the bloodstream, would normally be cleared by the kidneys. But in renal failure, it's not. And as a result of it, the macrophage monocyte system has to phagocytose it. And it leads to activation of these cells. And subsequently, you'll see spontaneous scarring develop in tissues, organs, and the skin. That's not because the deep dermal fibroblasts in the kidney became activated and it became scarred. And so it made us become interested in this. And so one cell population that we've studied over the years is the little green one off to the side there. And I guess I can point to it here. Yeah, right there, fibrocyte. And we developed a marker for it using 2D gel electrophoresis, but this is what the fibrocyte looks like. It's a bone marrow-derived cell that arises from the monocyte population. It can stain and produce collagen. It stains for collagen, produces, it looks very much like a fibroblast, except it's circulating in the bloodstream. And so in burn patients, these numbers of cells, normally present in less than 0.5% in the normal population, are increased, and they seem to be increased in the bloodstream in a fashion that parallels the expression of TGF-beta in the systemic circulation. The nice part is that we developed this antibody that would stain for fibrocytes called leukocyte-specific protein 1. And then instead of having to rely on collagen to differentiate fibrocytes from fibroblasts in the scar, we could have these nicely stained yellow cells and begin to quantitate exactly how many of these cells are there and what role they might play. And so you can see that in scar, there's more bone marrow-derived cells. They get better as the scar matures, but there's none in normal skin normally. So then we use the same scratch model that I described. And here's our jig, here's our scratch, and here's what happens when it heals. Part of it heals without scar, and part of it heals with scar. And so then when you look at the tissues where the scar is abundant, you'll see that the amount of fibrocytes present is 2 to 3-fold more than in the healed scar, which is an association, but it's not proof of too much, other than that they're there. So another condition, if you treat many burn patients, that we suffer considerably with and we have trouble understanding, is heterotrophic ossification. It's a condition in which scarring forms in the elbow that we sometimes think occurs from excessive passive range of motion that occur in people who are quite sick. Probably, Wendy, you're familiar with some of this from your nursing days. And it's a difficult problem because it's hard to treat and it recurs quickly after you excise it. When you take the tissues out, like I have on a number of our patients, you can explant them and the cells will grow out quite quickly. And then you can begin to look at the cells, and here they are here morphologically. They look like fibroblasts for the most part, but with flow cytometry and our double staining approach, you can begin to see that there's double stained cells present in this area that in many cases, 35 to 65% of the time, the cells that are present in those tissues are bone marrow-derived fibrocytes, which means bone marrow is contributing to the response to injury that occurs under the skin in our burn patients as well. So one of the approaches that you can take is by the understanding of how the cells move and traffic in the tissues. And there's a molecule called stromal-derived factor 1, or CXCL12. It's a chemokine that is involved in release from tissues that are damaged. And through the bloodstream, it will attract cells that are CXCR4 positive and chemo-attract them into the tissues. And we we have studied this. We found basically that there's higher amounts of FCF1 in the burn patient proportionate to the size of the burn injury and less in the age of the patient. We know with flow cytometry that there's a large number of these receptors are expressed on monocytes and very much more in the patients than there is in normal people. The problem with studying scar is that there's no model that is really very useful up to this point. Some of the red Duroc pig and a few of the others are they're helpful possibly, but they're difficult to work in. So we studied a type of mouse model in which we put human skin on the back of the mouse, and you can use the nude mouse. You could use the nude mouse, which is athymic, which has greatly reduced T cells, and that would allow the human skin to exist on the back of the mouse. But as we talked a little bit about last night, you can use other immunologically altered animals as well, and the RAG1 animals lack T and B cells, and the gamma C animals are double knockout animals that lack T, B, and NK cells. So they are virtually alymphoid. And so, you know, as we moved along, we thought that lymphocytes were very important in the development of scar, and there's likely one type that actually caused the problem. But in fact, the short of the long story is we still got the same scarring response in all three of these animals, which suggests that there was something else. So here's a picture of some of the scarring that you'll see. And we were a little concerned at one point whether this was sort of a partial rejected response and maybe it was an immunologic response we're seeing. It probably is, to be honest. But they get thickened scar. But it has changed us to the point where instead of being concerned about lymphocytes, we are now looking at some aspects of the monocyte population. And we realize that, as you might as well, that this is important in many facets of human disease, not just in scarring, in which polarized monocytes, whether they're M2 or M1, can be involved in a number of different disorders. And so from that comes a series of strategies. And if you're interested in this, the article in the Journal of Clinical Investigation is very helpful and interesting. So one approach anyway that we took was to use an inhibitor of CXCR4. And it's a 17 amino acid molecule that can prevent and reduce the amount of migration of monocytes into the tissues. And then we used our same mouse model, and here's some pictures of it. And if you look carefully, although it's a little while to kind of figure it out, you can see the amount of contraction present in the human skin is reduced. And when you measure it and quantitate it carefully, it's clearly significant statistically. There was less monocytes and macrophages and less myofibroblasts that were part of this as well. And the expression for TGF-beta was reduced by the use of our inhibitor, whereas decrin was restored in this tissue. So here is another kind of strategy in which people will start to look at. And again, you know, the world is really not obsessed with hypertrophic scars like I am, but the world is interested in fibrosis. So if you're studying pulmonary fibrosis or renal fibrosis or scarring in the liver, these kinds of things are fairly important. So now we're back to the combination of different games we're playing, and here we're using our scratch model again, in which we're taking the skin we put on the back of the mouse and we scratch it. And we uniformly a deeper injury in the skin that we know is supposed to cause problem in the normal human skin. And when you injure the skin, the scratch causes a increase in graft thickness. And it's associated with macrophages. But I think this is probably some of the best evidence that there's something happening of value here, because this is dark skin transplanted onto the mouse that has had the linear scratch. And we followed the animal for a year. You can see the epithelial cells are still present, a thick scar has developed and it's just sitting there. A lot of contraction occurred as a result of the original injury. And so this is a model I think that's of some value and requires some careful consideration. And I know from speaking to your group last night that they're able to take animals like this and begin to put certain parts of the human immune system back into them to start to ask questions what the response will be. So I'm hoping that will allow us to be understand more about scar than we know up to now, which is still not great. So does any of this information I showed you about the understanding of scar allow you any helpful information apart from the opportunity to come and talk about it? And well, we were involved in interferon because at one point we thought interferon was a useful antifibrotic molecule, and we did a clinical trial, phase 2 trial, and then a phase 3 study in which we studied more than 20 patients in a blinded fashion, administering it in an approach very similar to what would be used for the treatment of hepatitis. And so then we followed those patients for a 20-week period of time, and then we ultimately saw these kinds of results photographically, in which the red aspect of the scar would go away very quickly, and the scar would develop a suppleness that we were unaccustomed to seeing, kind of a rubberiness and a pliability that was very important to us. And then we tried to measure this using a Vancouver scar scale that we had to modify. But in doing that, we gave all this blinded data to a statistician, and he broke the code and modeled the data and used multifactorial regression. And what he did is he showed us that scar gets better on its own if you treat it with a placebo or nothing. And that's what the black line is. So, but when we used interferon, you can see there is a benefit over and above that which would occur with the placebo. And with statistical analysis, this benefit from the placebo was statistically significant. But the benefit from the interferon treatment was also significant over and above that which would occur with natural production. And herein is the challenge for the management and the treatment of scar, because it gets better on its own. Things that you do that you claim to be worthwhile and are expensive or time-consuming should be somehow better than what would occur if the scar was to get better on its own. So some of these patients, we could study them doing the same kind of thing, and here's short of the long story is that without interferon, the level of the CXCR4 cells basically didn't change, but in the interferon-treated patients, the levels of CXCR4 actually went down. Another molecule which resembles interferon is IL-10, and there's a group of people in Cincinnati, the pediatric hospital there, that are quite strong on IL-10 as a molecule which has benefit. And in fibroblasts, you can see similar things to what we saw, reduction in type 1 and type 3 collagen, alpha-actin, and others. And they figured out quite nicely with the inhibitors to the receptor and also the transduction mechanism that, that it signals through the AKT and STAT3 system and has a putative antifibrotic effect. A little bit about surgery. Maybe you guys, most of them I think are surgeons, and this is one of the cases that stimulated me as a child who lived in northern Alberta, who didn't have gas and water or heat or anything like that, and their parents trapped, and they would hand the furs on the on the trees outside this big fire, and the child fell into the fire and burned his palm. We're really privileged in Canada, but this was 35, 40 years ago. And this child lived in the bush without getting any care and had bad scarring until finally we saw him. The whole world in our part of the world is not that bad, honestly, but but here's another case, a young guy who was 85% burned, that we grafted the skin onto what I thought was the deepest burn of the hand. He only had a small amount of donor site. In the area that I couldn't graft, which I thought was the less deep burn, was allowed to heal. And you can see he can't move the hand that went on to develop scarring. So it's a good test of the fact that a skin graft on a deep wound is a useful thing to allow people to get range of motion and control their contraction. Can you assess wounds to figure out who needs a graft or who's going to develop scarring? Well, you'll see there's a number of scanning laser Doppler devices that are out there now, and the one that we have, we think, has a positive predictive value for grafting of about 90%. When you follow people and you watch whether they heal or not. And this is what the images look like. In the red area, you can see there's blood flow. In the darker areas, there's not. We tried to also use biopsies, and as Lillian Nanley suggested to us, Vimentin is a good biopsy, a good marker that use image chemistry to determine where it's deep and where it's not. And so with biopsies, we thought there was a general agreement of about 94% that the depth of injury as predicted by LDI was found to be similar with the biopsy. And in those deeper areas, there was TGF-beta present in the injured tissue. So, I'm a surgeon, I do surgery too. I'm a plastic surgeon, which is many times good, but not always. Anyway, you in this part of the world will see many more of these patients than I will in my part of the world. But this man had 15 different operations starting in Africa and moving into Canada, and it was difficult for him. He couldn't work. He had a wife that cared deeply for him and had to support him, and he was difficult times for him. And he was sent to me by one of my colleagues who didn't kind of want to be number 16. And so basically, you can ask yourself what you might want to do with this, but what I did is I cut it off. Big tumor. And then what I did is I used the anterolateral thigh flap and microsurgical reconstruction in his neck and switched one tumor for another. So you can see from his picture, now he's got this big mass in his neck from the flap that I put there. And then I irradiated him with radiotherapy afterwards. But then you can go back and defat it and improve it. And this helped this man quite a bit to get back into a life that got him where he needed to go. But I caution you, because in my practice I also have this patient. This is someone who came in with this tumor in his arm, and as you saw in the upper left there, that, you know, he was 50-some years old. He was living with this, and I don't know for how long or why. He was, on the face of it, very nice, pleasant person. But ultimately we imaged it and then had to resect it. You can see we took off some of the superficial tendons. We were able to leave his median and ulnar nerve. His radial artery was reconstructed. We grafted him and his hand function came back and things were good. And he became my sailboat instructor. Now, I'm trying to sail a Hobie cat and could never get good at it. But he gave me papers and information, and I'd see him periodically. 5 years later he came back with a mass in his chest, and I had to resect that too. But the key is that this guy was injured he had suffered a burn injury as a child. He was cared for in Britain, and when he developed hypertrophic scar, they irradiated all the scar to try to treat it. And as a result of it, he developed that lesion, and the same on his chest. And then he came back a number of years later with the same lesion on his scalp. And so radiotherapy, although people in the world talk about this and they say there's never been any cases reported, and we have just recently tried to describe this so people know about it. It's not something I think is good for especially children. I wouldn't go anywhere near a child with radiotherapy with these kinds of lesions. I'm going to go backwards. Another approach, and I need to kind of move along here, is the use of artificial skin, and this is Integra. I worked in Boston with Dr. Burke, who developed a form of dermal lattice that was quite useful for acute burn management, but it still develops a period of inflammation, immaturity that's associated with its healing. And this is a patient of mine who was 28 weeks pregnant when she was burned 50% total body surface area. And it was a lot of fun operating on her with her pregnancy, having to use wedges to keep her off the baby off the inferior vena cava. And the first time or two, there was a lot of bleeding that was very impressive. And so when she got better and her skin grafts healed, and then she went on and delivered her baby, and the baby was normal, I thought, boy, we're in good shape. But she developed scarring like crazy, and it was a very difficult thing, not only on her face and chest, but in other parts of her body. So we did some test patches on her other extremities to find out whether Integra worked before we actually went ahead and did her face like this, and she did quite well. Another challenge, and I apologize, this is not something, if you're not in this field, you don't get warm to this kind of case easily. It takes a lot of kind of repeated exposure to handle the stress of just the images even. But anyway, this is a man I was asked to see by my junior colleague. He was asking me to come to agree with him that compassionate care is the right treatment for this man. He was a 28-year-old guy who was removing linoleum from the floor of a new house that wasn't the color that the owners had chosen. So he was using a solvent to take it off. And there was a heater in the house. The fumes got sucked into the vent and an explosion occurred and he got badly burned. And he was burned about 92%. You can see a small strip on his hip and maybe a little bit on his lower abdomen. And this is a difficult challenge. How do you deal with this? So this is where my friend Steve Boyce came, because Steve Boyce worked with John. They were interested in tissue engineering of the skin, and they worked together to develop techniques in this regard. And Steve went on to Cincinnati, where he perfected some of his techniques, and I just happened to be lucky that I fit into a point in time in his clinical trial that one of our cases could be dealt with. And so we sent him a biopsy. He explanted the skin, grew the fibroblasts and the keratinocytes, and within a month he was coming back to us with there's a little bit more than this, but not much, series of skin grafts that we could use. And so we went all summer long, once a week, grafting him. And this is the material, the dermis that's there, and this is what the product looks like. And if you look at this carefully, you can see that if you tried to rub that off, you'd have a tough time. And you can see there's little gaps, but it looks like those little gaps in between have filled in. And in fact, they have, and it's because there's enough stem cells in the keratinocyte population that they have migratory abilities can heal the interstices. So there's been 100 and some odd patients in Cincinnati treated, 1 in Edmonton and 10 in Sacramento. And the FDA now is standing in the way of having this move forward because of a number of sort of protocol violations related to when you took the pictures and when you did the biopsy and a number of other things. It's, I think for the burn community, it's very disappointing because there's people's lives at stake here, and this product actually saved the life of my patient and reduced the morbidity considerably. So we used Integra. It got rid of the eschar and then used cultured skin substitutes. And this is what it looks like. My partner took the Integra off before we put Steve's skin on because he wasn't sure, and every time we did the resurfacing. And then the last case, I put the product right on top of the Integra and it was fine, and it gave a better cosmetic result. But my patient got better. And what I didn't tell you is that when I went to see the patient and I had to talk to his family, I talked to the patient first. To be honest, anyone that's 27 years old, they don't want to die. And I don't even like to have to ask them, but you owe it to them to do that. And then when you go talk to his family and his wife's there and you find out that she's 6 months pregnant, it's a tough message to deliver for anybody. But I went back to him and I said, you know, this is going to be a real long shot for you to get better, and in the course of it, it's stressful. And the stress actually could have a negative effect on your wife's pregnancy. And so we need to be careful about what we do here. I couldn't quite say it like that, but it didn't change his mind. He wanted to get better, and he did recover. So you can see there he is, and he's a burn victim about 3-4 months out. No, sorry, he got better. He was injured in May. He was in the rehab hospital in early September, on his feet and out of the hospital after that, and that was related to his skin. So part of it is fixing the deformities that come with it. For him to be able to walk down the big mall in Edmonton called West Edmonton Mall, he can't have that nasal deformity. It attracts attention to his family and makes life with his family difficult. So at the same time, reconstructing him when you have skin grafted forehead and grafted face is not an easy thing either. But with the Doppler, you can find the artery, and then you can start delaying all these flaps, and that's basically what I did over a series, 4 different delays, and then I used his ear cartilage to reconstruct his nose. And the problem is, after about 4 hours in the operating room, 5 hours in the operating room, I'm getting ready to quit, and I turned the flap down. I'd already turned it down 3 weeks or 2 weeks before, and it seemed to be fine, but I put it back. So I turned it down after having done all these things, and I got it there, and the tip of it started to get blue. And I knew immediately that if that was left, it would die and I'd have nothing. So I plucked those little guys out of a pickle jar on our ward on 3C3 myself and brought them back immediately. So as he was waking up in the burn unit, he had these little black critters wiggling around on the end of his nose. And they decongested the whole end of his flap, and it went on to survive. So there he is actually with his nasal defect. And we couldn't close his forehead, so we just left it open and it contracted with time, and he did fine. So now this guy actually is recovered. He's alive. He works. He has a business. Much of his business is teaching people safety in the workplace. But he's just come back from his holiday in Hawaii this year, and he's a happy, outgoing person that is happy to be alive, and it came from tissue-engineered skin, from somebody that helped us, that worked with John and was influenced by him. So I couldn't not show you this case. We do the same thing ourselves now because it's not available. This is our product, tissue-engineered skin, and this is our attempt to show you that when you use deep dermal fibroblasts in tissue-engineered skin as you make it, that there's more contraction with the deep dermal fibroblasts, and the matrix actually is stiffer, and there's less tensile strength when you use deep dermal fibroblasts. So tissue engineering going forward might be selective in terms of the fibroblasts that you use. We use pressure garments. At one point, our group was the one that said there was not enough proof and it's expensive and causes complication. But thankfully, Lauren Angrove was able to show in a large study sponsored by the NIH that pressure garments were effective. And we also use silicone gel and provide treatment in those fashions. But there's still some debate as to how useful these things are in large Cochrane studies. And still, at this point, in July of this last year, there is difficulty in people being comfortable with the fact that we've got enough well-designed studies to know exactly what to do with scar. So then along comes laser treatment. And there is a lot of laser work out there, and and a lot of different approaches to it. And there is beginning to be some scientific approach and thoughtfulness goes into this, because it's likely that the flash lamp dye-tunable laser improves the redness that's present in scar. And on the other hand, some of the fractional ablative and non-ablative lasers are being designed to punch holes in the scar to try to increase the flexibility of the scar. And this paper actually by Scott Hultman just came out actually, and suggests that in patients that were 3 different sessions on average with a combination of flash lamp dye-tunable laser and ablative lasers, that their scar were better than before they were treated. But again, if you remember back to what I showed you about interferon, people get better spontaneously. So because you've got an improvement that occurs after you've treated, does not necessarily answer the whole story. It suggests that there may be something there, but the proof is still lacking. But this is the Japanese approach. Rei Agawa, who's an expert in a lot of this as well, has used a YAG laser to treat scars like this before and after, which I think is useful. And he quantitated it using a Japanese scarring system to show a demonstration of improvement. But he was honest enough to suggest that in certain regions of the body that scarring recurs afterwards. And for most of us that care for burn patients, it's a tough concept to take somebody that you've looked after for a long time, help them get their wounds healed, and you're going to come along again and burn them with a CO2 laser. So this is part of what makes the adoption of this difficult. And here's a case where the traditional approach to many scars in which you use Kenalog or triamcinolone, that when combined with laser leads to a breakdown and a lack of healing and the ongoing development of scar. So, I don't know, laser might work like microneedling. Microneedling is a technique you'll see in the Orient where they use these small rollers with micro needles and they poke little holes in the scar. And there's lots of over-the-counter-like approaches to the management of scar, and this is one that might have some basis as well. But I would tell you, in your community, I got to know Peter Schumacher. He works in the military hospital, and Peter is I think an honest and certainly very friendly guy that is beginning to influence me, and I'm using some of his approaches with the flashlight dye-tunable laser to begin to look into this more, and I would urge the younger members of the population to think about these kinds of things as well. So this is sort of a summary saying that it may be useful for children and adults, and that the pulse dye lasers are good for red, immature, early scars, but the fractional lasers may be important more so for the deeper scars where you're trying to improve texture and contour of the skin. But still, randomized studies are likely required. And so that's all I'd like to tell you. You've been very good about listening to me quite a long time, and I consider it a privilege to come and speak to you on behalf of our organizations, and to meet John's family again, and to view your beautiful campus, and I thank you for your consideration.